Bismillah ar-Rahman ar-Rahim. Welcome everyone in this meeting of Egyptian Society of Nephrology and Transplantation, continuous medical education chapter meeting, which is really a very distinguished meeting today. It is a clinical forum, one of our clinical forums, but that's what distinguishes this meeting is that it's presented by our dear colleagues in Libyan Society of Nephrology and Transplantation, led by Professor Abdul Hafiz Ali Shaybani. Professor Abdul Hafiz is the head of the Libyan Society of Nephrology and Transplantation and the professor of nephrology in Tripoli University Hospitals. I am really pleasured to have Professor Magdi Sharqawi today to co-moderate this session with me. Professor Magdi is professor of nephrology and medicine in Ain Shams University in Cairo, and he is the vice president of Egyptian Society of Nephrology and Transplantation. We are expecting a very fruitful and heavy scientific discussions following the cases, as we have now many of our professors joining us successively. Professor Shams Sayed, President-elect of the Society, Egyptian Society, and Professor Said Khamis, Egyptian board member and emeritus professor in Menofia University, Professor Riyad Saeed, past president of Jordanian Society of Nephrology and Transplantation, and many are joining our successively today. Before we start this meeting and I leave the floor to Professor Magdi and Professor Abdul Hafiz, I would like to thank our coordinator today, Dr. Rami Abu Bakr al-Shahat. Dr. Rami is the fellow of Edinburgh Royal College of Medicine and Egyptian board certified and nephrology consultant. Thank you, Dr. Rami, for all of his work regarding this meeting and all of CME chapter meetings. So please, Professor Magdi, start.
Assalamu alaikum. I'd like to welcome you all to this first joint scientific meeting between the Egyptian Society of Nephrology and Transplantation with the fellow and the dearest Libyan Society of Nephrology and Transplantation. It is a memorable day today, and we are lucky to have three distinguished consultants from Libya. Professor Abdul Hafiz Shaybani is, of course, a well-known consultant nephrologist and professor of nephrology, and he's the head of the Libyan Society of Transplantation. And we will start with him today with case presentation, and let's go immediately in order to save the time. Professor Abdul Hafiz.
Assalamu alaikum wa rahmatullah. Thank you very much for these welcome presentations. We are really honored by the presence of these distinguished professors to attend this meeting. It is the first meeting, and we hope it will continue after that. I will start straight away to the case. We have a taxi driver who is 36-year-old male, was referred to Tripoli Medical Center for evaluation of proteinuria and skin rash. He presented complaining of painful peripheral sensation both hands, triggered by turning on the air conditioner while driving. He denied episodic fevers or abdominal pain or bone pain or arthralgia. There was no history of diabetes, hypertension, hematuria, or family history of renal disease or any other inheritable disorder. The physical examination showed that the patient demonstrated normal physical and mental development. He has a cutaneous lesion. Cutaneous lesions, it looks like a clusters size of 1 to 5 millimeter. The color is deep red to purple, and they are papules and filled with fluid. And the reason why he came to the hospital, because he's preparing himself to get married, and this kind of rash, skin rash, disturbed him, and he tried to get married without this rash. That's why he was seeking an advice, medical advice. The lesions were distributed symmetrically and involved the lower back, hips, buttocks, thighs, scrotum, and penis, with a few lesions involving the lower lip. Examination of the extremities did not show edema or varicosities, or hepatosplenomegaly also wasn't present. This picture showed the type of rash he's having. It's asymptomatic, painless, multiple red-purple papules. They were symmetrically distributed on the lower back, as I said before, hips and thighs. Strange rash. If you go back to the history doesn't show any using of specific drugs, or as I said, or any other systemic disease, and there is no organomegaly, so it's quite a rare kind of rash that doesn't fit any form of the usual representation. And the urine analysis showed that pH of 5.4, negative for ketones, and normal microscopic finding. I mean, no blood, no casts. We measured the 24-hour urine collection, showed protein excretion of 1.4 gram per day. His serum albumin was also normal at 4 gram%. Serum and protein electrophoresis were negative for monoclonal proteins. Complement C3, C4 were normal. Anti-neutrophil cytoplasmic antibody negative. Anti-DNA antibody was negative. Hepatitis serology negative as well. So serologically doesn't show some sort of any autoimmune disorders. Renal ultrasound showed a normal sized kidneys bilaterally. I would like to go to the next slide. So the problem was how to ascertain the cause of his skin lesions. So a skin biopsy was performed and showed this kind of picture. And the right side is a normal skin picture, skin histology picture, and the left side showed the patient's skin biopsy. There is a proliferation of dilated upper dermal layer vessels that are lined by thin endothelial cells, overlying the epidermis, and showed light hyperplasia. This also doesn't explain a lot of causes, so we went straight away to the kidney biopsy, and kidney biopsy done because of the presence of proteinuria, an unknown cause of the kidney disease. We have taken two samples of the kidney biopsy, two goes. We tried to get two different labs results. The first sample was sent to our Tripoli hospital laboratory for histopathology, and the other one sent to Cairo. And both of them came with the same results, that this patient has a rare disease. If you can see this picture of the biopsy, the glomeruli showed that looks like there's something of like spaces here, looks like spaces. And if you go with the deeper, closer look, you see the glomeruli showed vacuolated, foamy appearance of the cytoplasm of their epithelial cells, and mild focal lymphocytic infiltrate tubules also showed vacuolated cytoplasm. So this peculiar picture always indicating to a disease. If anybody know, let me know about it before I go to the next slide. As I said, both results of the biopsy came the same results from Tripoli or from Cairo, and showed this patient has a very rare disease called Fabry disease. Then we went to the serology to check about the enzyme called alpha-galactosidase. And usually in people with the Fabry disease, they have a very, very low of this enzyme. So it was nearly zero, as you see, of the patient regarding to the reference range. So this also confirmed that this patient has a Fabry disease, and Fabry disease is a well-known disease, first described in 1889, 1898, by the two scientists called Anderson and Fabry. Anderson, I think, from Sweden, and Fabry from Germany. the disease is caused by deficiency of the lysosomal hydrolase alpha-galactosidase A, alpha-Gal-A, resulting in accumulation and storage of globotriacyl ceramide, GB3. So GB3 will be accumulated. So it's a kind of metabolic storage disorder, and we know that there are different types, either glycogen storage disease or mucopolysaccharidosis or lysosomal storage disease. And our Fabry disease is here in number 3. It's the lysosomal storage disease. And when you see lysosomal storage disorders, you see a lot of diseases here. One of them is Gaucher disease, Hurler disease, and you see here Fabry taking only 7% of these lysosomal storage disorders. Let's talk about Fabry disease in a small print. Fabry disease is a rare, X-linked lysosomal storage disorder which results from a deficiency of the enzyme alpha-galactosidase A. It first was described more than 100 years ago because of its characteristic skin lesions known as angiokeratoma corporis diffusum universale. The lack of the alpha-galactosidase A leads to incomplete metabolism and ongoing lysosomal accumulation of glycosphingolipids, mainly globotriacyl ceramide, which is also called GL3, in the lysosomes of various cell types and tissues. Particularly involved are vascular endothelial cells, glomerular and tubular cells of the kidney, cardiac myocytes, and neural cells. So it's a multi-system disease. And neuropathy is one of the, or nephropathy is one of the major complications of Fabry disease. Kidney biopsy showed galactotriacyl ceramide accumulation in tubular epithelial cells, glomerular cells, endothelial cells, and vascular smooth muscle cells. So progressive accumulation of this material leads to microvascular dysfunction, occlusion and ischemia, and subsequent development of tubular atrophy, segmental and global sclerosis, and at the end, interstitial fibrosis. So it will end to a kidney failure. Affected male individuals classically develop the stage kidney disease by the 4th decade. So what is GLA gene located? It's located at the chromosome 22. Is located on the long Q arm of the X chromosome at position of 22. More precisely, the GLA gene is located from base pair this number to base another number on the X chromosome. Fabry disease can affect both men and women. Although historically described as an X-linked recessive disease, recent data showed that heterozygous women can also be severely affected. Female Fabry patients can show a broad variety of disease severity, ranging from an early asymptomatic to end-stage kidney disease. This disease is progressive and presents as a multi-system disorder with the potential vital organ involvement and life-threatening complications. This is a picture showing that proteinuria might present late. So the first symptoms will be neuropathic pain in the peripheries and ophthalmoplegia, gastrointestinal problems, and then the skin lesions will appear late, angiokeratomas and proteinuria. One of the earliest and most debilitating symptoms is neuropathic pain with episodic excruciating pain, crisis triggered by fever or physical exertion. That's why when he's also he likes to use the air conditioner when he's driving, because he cannot tolerate the heat. Other early manifestations typically include lenticular and corneal opacities, angiokeratomas, hypohidrosis, and abdominal pain and bloating. During the 3rd and 4th decade of life, the disease is characterized by the progressive course and severe morbidity and mortality due to cardiac, renal, and cerebrovascular involvement. Renal damage is caused by diffuse deposition of GL3 in the glomeruli, the tubular system, and vasculature. Light microscopic findings include the foamy appearance of the glomeruli with diffuse swelling and vacuolation of the visceral podocytes. Electron microscopy showed podocytes and mesangial cells filled with lysosomal electron-dense granules arranged in a laminar myelin sheet. Looks like a zebra, skin of zebra. Microalbuminuria or proteinuria is probably the earliest clinical manifestation of Fabry nephropathy, which can be identified by routine medical check. Typically, elevated serum creatinine values and a decline in GFR developed during the third decade of affected males. Like in our case, he was 36 years of age. Prevalence of Fabry disease among all causes of end-stage kidney disease ranges from 0.017% in the United States to 0.19% in Europe, with increased morbidity and mortality comparing with the average access population. This is an electron microscope picture showing electron-dense laminated myelin figures in glomeruli and glomerular epithelial cells. You see, it looks like a zebra skin, white and black, white and black, and white and black. So why we have to screen for Fabry sometimes if you have a patient with high index of suspicion? The rationale for early detection, because earlier therapy will protect the organ and give the best results. Genetic counseling informed reproductive advice is very beneficial, and screening maybe identify undiagnosed relative having the disease. And that's what happened in our case. We went to the families and we screened, and we find other 4 members of the family having the same problem when we did the kidney biopsies and we screened for the enzyme. How we treat this patient before I end, it's an enzyme replacement therapy. The availability of enzyme replacement therapy with recombinant alpha-gal has offered the promise of altering the natural history of the rare form of proteinuria renal disease. There are 2 forms of early replacement therapy available in the market. It's very expensive, by the way. Either Riblagal, it's alpha-galactosidase alpha, Shire human genetic therapies, an American one, and the Fabrizyme is alpha-galactosidase beta. It's enzyme also from the USA. With the exception of the structures of the oligosaccharide side chain, the primary amino acid sequence of the gene products are the same. So we approached these 2 companies. We tried to bring the enzyme from them, and it was very expensive. And then we decided to bring the Fabrizyme. They were very easy to approach, and they bring the material or the medication very quickly. So the approved doses of A-galacidase alpha and A-galacidase beta are 0.2 and 1 milligram per kg intravenously, bi-weekly respectively. What about kidney transplantation? If you have a patient on dialysis and it proved to be a Fabry disease, would you transplant them or not? So renal transplantation is available for patients with end-stage Fabry disease due to endogenous alpha-gal A production from the transplanted kidney remains. And I think this is the last slide. When we have to think about Fabry disease, we have to think about it as when we have unexplained chronic kidney disease, when we have a cardiac involvement like left ventricular hypertrophy or arrhythmia for unknown cause in a young person, or if we have a chest pain with a negative cardiac cath, if a patient presented young with a stroke or TIA, or unexplained myalgia or arthralgia, or he complained of sensory peripheral neuropathy or angiokeratomas. And thank you very much for listening.
Thank you, Professor Abdul Hafiz, for this case and for the theoretical background. Professor Magdi, please.
Okay, thank you. Dr. Abdul Hafiz, it is an interesting case, and it's not usually common to find patients with Fabry disease because the difficulties in diagnosis. Even with biopsies, some experts in biopsies cannot detect the Fabry disease and can be mistaken for several other diseases. But this was a very clear biopsy finding that diagnosed the patient, and the angiokeratomas is a hallmark of treatment in such patients. The age, usually in Fabry, there are 2 types of Fabry. Some come in children and usually have neurological symptoms, and other came in adults and usually in the kidney as well as in the heart. Although it is a rare disease, but I have seen two patients throughout my life. Both of them went into renal dialysis. One of them has just visited me today seeking transplantation. And answering your question, it is not contraindication to transplantation. But let us keep in mind that they usually in the Western countries transplant this patient from a cadaveric kidney. And the outcome, most of the studies in February was a case studies. There is no randomized control trials. Our case series, many of them have shown that there is recurrence after transplantation, but the survival of the kidney is almost identical to patient without Fabry disease. So it is the best choice for the patient to go into transplantation, and he may need to use the Fabrizyme throughout his life for preventing
Absolutely.
rapid decline of the kidney function. So it's
Thank you,
open for
Very
discussion.
good.
We have up to 5 minutes for questions and answers.
Okay, Professor Magdi, if you have many comments, I don't see questions. Many comments that Fabry's needs, as you said, lifelong treatment with the enzyme, 5% recurrence of transplantation. And the comment, Professor Hisham Sayed, please unmute yourself.
Thank you very much, Dr. Abdulhamid. Very interesting case, although straightforward in diagnosis, but the landscape of management is scaring. I agree that with Magdi that Fabry disease has no hope except for transplantation. As the disease progresses with decades of
The
life,
enzyme.
yes, this patient presented late, not as childhood Fabry disease. So I think the only hope is renal transplantation, and we have to proceed. The question is from whom the transplantation? As the family, you may correct me, need also screening for genetic diseases.
Okay. Professor Magdi.
Yeah, yes, Dr. Hisham mentioned a very, very important thing, because Fabry disease should be searched for. Most of the patients have mild form of the diseases of this Fabry disease, and so you have to screen the family. Even it is an X-linked disease, but sometimes it may be aggressive even in females.
Okay.
And so you have to screen all the family, and you have to
That's what we
screen
did.
relatives, not just the patient close family, but the relatives. You might find many of them have this mild affection, and we won't accept any of them if they have this Fabry disease. And we can do a whole exome sequencing to diagnose the diseased gene, and they are thinking now of CRISPR to correct this gene. So he should receive a kidney from a patient, from a donor with no Fabry disease.
Okay.
True.
Thank you, Professor Magdi. Let we move to the second case.
عاوز نخش على الحاجة الثانية؟
تفضل كم.
I enjoyed the comments of my colleagues, both of them. Yeah, they are thinking that the enzyme replacement is not the right treatment. They should be transplanted, but from the proper donor يعني اللي هو he's free of the disease. فخلينا نخش على الحالة الثانية.
تفضل.
If you don't mind.
تفضل يا دكتور عبد الحفيظ. تفضل.
يلا سيدي. You need just a minute. Could it be this one? Or this Fabry? I need help. هخش على المين الصفحة بتاع الكمبيوتر بتاعي. Let me go back. أيوه. This is finished. The second case, already got it. Okay. Here we are. Case 2, are you listening to me?
Yes, تفضل.
Is my voice heard?
Yes,
Okay.
clear.
So this is a young, this is a young female, 24-year-old female patient who has been transplanted in Pakistan a few months ago from a non-related donor. This is what we call a commercial transplantation, which we are all against because it doesn't follow the rules and the ethics of transplantation. She presented with a sense of weakness, weight loss, deterioration of renal function. She was on hemodialysis prior to kidney transplantation for 2 years on dialysis. No other members of the family has kidney disease, as it appears from the history. We did this investigation, showed that serum creatinine is 4 mg/%, blood urea 150. Abdominal ultrasound showed grade 1 nephropathy. It's not bilateral, it's just the transplant, the graft showed grade 1 nephropathy, urine analysis, hyperproteinuria, IC is over 100. So we are dealing with hematuria and proteinuria. And we did the 24-hour proteins. It's quite significant, 6.5 gram during the day. Again, anti-nuclear antibodies, anti-double-strand DNA, anti-nuclear antibodies, also CNP, ANCA CNP were negative. The complement was normal, and hepatitis screen was negative. So we are in a dilemma, actually. Hematuria, proteinuria, rejection. Is it a rejection? Is it just a drug toxicity? Or it is an infection? So all the differential diagnoses were running in our mind, but immunologically, everything was normal. There's no involvement of the immune system in a way of complement or antibodies. Serum calcium was 10.5 mg/%. Serum phosphorus was high. Uric acid was 8 mg/%. CBC hemoglobin was 11.7. Total leukocytic count 8,000. Platelet 300. So hematologically was okay. Total protein was 8.2. Serum albumin was 4.7. So in spite of heavy proteinuria, she's still maintaining a normal serum albumin. Normal liver enzymes and CRP was negative. Regarding the drug treatment, she's on cyclosporine A and MMF and prednisolone. She didn't miss any dose if you are thinking about missing drugs or rejection or under treatment. Drug level of cyclosporine A within normal level. So this again makes us in a tricky situation. Ultrasound, normal size graft, obstruction, normal coagulation screen, and advised for kidney biopsy. So this is again one of the cases where you have deteriorated graft function without any clue for the cause. History wasn't helpful, immunological screen wasn't helpful, drug levels were normal. So what happened, we don't know. But straightforward, we have to do a kidney biopsy. What to do next? Kidney biopsy, of course. Kidney biopsy showed calcium oxalate deposits in the urinary space and in the renal tissue. This H&E polarization microscope. You can see some polarized crystals here. Strange. So we decided to send the kidney biopsy abroad. Again, the same picture. We decided to send the kidney biopsy abroad for re-evaluation again. So we send it to France, hospital in Lyon, France, Dr. McGregor, and he said cortical specimen of 80 glomeruli are observed, no obsolete glomerulus. Diffuse ischemia, no glomerular lesion or otherwise. Tubules, important tubular lesions, dilatation and atrophic tubules. Vacuoles, again we are with the vacuoles, epithelial desquamation. Numerous epithelial, granular, and oxalate casts. So there is a clue now here. We have seen a lot of oxalate casts. The interstitium, diffuse fibrosis, multifocal sclerodema, and scattered inflammatory cells. blood vessels subnormal, and arteries are subnormal. Conclusion, chronic interstitial nephritis with numerous casts, primary oxalosis. And then he said maybe drug toxicity, maybe he wasn't aware of the proper history. Usually we have to give them a proper history, the histopathology, to help them in the limiting the differential and narrowing the differential diagnosis. So the diagnosis was primary hyperoxaluria. Primary hyperoxaluria are rare, important error of glycosylate metabolism characterized by the overproduction of oxalate, which is poorly soluble and is deposited as a calcium oxalate in various organs. The increased production of results in increased urinary excretion of oxalate, leading to a kidney injury and in some cases to end-stage kidney disease. Genetics of primary hyperoxaluria. Primary hyperoxaluria is primarily caused by autosomal recessive enzymatic defect, results the enhanced oxalate protection. There are three types actually: primary hyperoxaluria type 1 and type 2 and type 3. Type 1 is the commonest type, is 70 to 80%, based on the clinical observational studies, is due to the variant of AGXT gene that encodes the hepatic perioxymal enzyme alanine glycosylate aminotransferase. Type 2, 10% only, is due to a variant glycosylate reductase hydroxylate pyruvate reductase that encodes the GRHPR gene, another gene, so different genes. Primary oxaluria type 3 is the lowest percent, 5% only, is due to a variant of another gene. So there's different defective genes, but the commonest gene was the first one, type 1. But all we know that primary hyperoxaluria is contraindicated for transplant. If the patient diagnosed beforehand, before he goes to a transplant, he should be forbidden from taking a kidney transplantation. Increased urinary excretion of oxalate results in oversaturation of the urine with the calcium oxalate, leading to kidney stones. So usually this patient presented with multiple kidney stones through calcinosis, but not in our patient. Our patient was, his kidneys, the previous kidneys, the native kidneys were normal. There is no any nephrocalcinosis. Recurrent stones and progressive nephrocalcinosis cause kidney parenchymal inflammation and fibrosis, which lead to end-stage kidney disease. Kidney function deteriorates, plasma oxalate increase further, leading to calcium oxalate deposition into non-kidneys tissue. Systemic oxalosis, leading to retina, myocardium, vessel. Again, it's a multi-system disease. For patients, for all forms of the primary oxalosis, high fluid intake, greater than 3 liters per day, is routinely provided to decrease tubular fluid oxalate concentration and diminish intratubular oxalate deposition. The goal is to maintain urinary oxalate concentration below 0.5 millimole body surface area per day. For patients with type 1 and 2, we suggest the use of agents that increase the solubility of calcium oxalate. This is grade 2C. They advise to use oral potassium citrate at a dose of 0.15 gram per kg, divided into 2 to 3 doses per day. For patients with primary hyperoxaluria type 1, they suggested a 3-month trial of pyridoxine grade 2C in approximately 30% of patients with type 1. Pyridoxine reduces urinary oxalate secretions. Pyridoxine is not effective in type 2. Again, more explanation. I don't have many slides, don't worry. In patients with the primary hyperoxaluria type 1 and end-stage kidney disease, the main option are combined liver and kidney transplantation, or sequential liver first and then kidney transplantation. So we are facing a patient who has been transplanted abroad in Pakistan as a legal way, as a commercial transplantation, without taking the precaution that disease might be recurrent. Disease is contraindicated to be, this patient contraindicated to be transplanted. And it's, again, a lesson and a message we have to learn that commercial kidney transplantation is a very high risky and doesn't follow the rules that we all agree on. Until more data are available, better to perform combined liver and kidney transplantation. For patients who are pyridoxine sensitive or have a late onset form of the disease, isolated kidney transplantation might be possible. Thank you very much.
Professor Abdul Hafiz for this case and the clear message. Professor Riyad Saeed wants to comment. Unmute yourself.
Yes. Well, thank you, Dr. Abdul Hafiz, for this nice. But really, what's the primary kidney disease in this young lady? Do we know what's her primary disease? Is it oxalosis? She's known to have oxalosis?
Actually,
Not known.
we saw her after she has been transplanted, so we don't know about
Okay.
the situation
Yes,
before
that's
when she was on
exactly.
dialysis.
So really, do we have gene study on her later on to document that, she has oxalosis? Because really, the
No,
kidney
we don't.
ultrasound that you mentioned, we don't. Okay, because the ultrasound that you did on her native kidneys showed no stones. Now that will bring
Exactly.
you, what they raised from France, that this could be really drug related. We have a similar case after 14 years, lost first kidney transplanted with weight loss and others, especially in females, what we call juicing. They try to lose weight. What they eat, high load of oxalate in their diet. That's one thing.
Yeah.
In addition, high dose of vitamin C, usually the combination of both will cause oxalosis. So that's really plus enteric, causes of hyperoxaluria. So really, this patient should be worked up. It's easier to say that this is primary hyperoxaluria, but we don't have any stigmata so far in this patient. So I think we have to dig deeply into what else caused this. Mainly if she's trying to lose weight, eating a lot of juices, try to detoxicate herself, by that's really, we have similar case, but that she lost the first kidney after 14 years without anything. Then second kidney lost within 6 months. And third to be, she was really trying to lose weight, and that was the end result of it. So it's so easy to say primary hyperoxaluria, but we can do gene study on it. Thank you. Anyway, it's a very interesting case.
Thank you, Professor
Thank you very
Riyad.
much. I just
regarding your
want to
comment,
comment, please, Professor Yasser. I would like to say something, please, for the comment of Professor Riyad Saeed. He was very true in saying that the history wasn't helpful at all. We expect to see some kidney stones. We expect to see some nephrocalcinosis, but that wasn't the case. So really, it's not straightforward. Maybe this is one of the unusual cases that presented. As you know, we all know that in medicine, we don't have sometimes a clear-cut cases that comes in. Sometimes we see odd cases. So this is, I think, one of them, that we don't have a clear history. Family history wasn't suggestive of stone former. But when we did the graftectomy in this patient, and we sent to the histopathology, it was full of oxalate. There's no doubt about it. We have taken the whole, she's back on dialysis, and then, this is my comment, actually.
Thank you, Professor Abdul Hafiz. I can, my comment was on this point, exactly that. I can remember a patient was diagnosed to have oxalosis post-transplant, and the original ultrasonography pre-transplant didn't have any stone. But when we looked for his plain UT, we found some sort of kidney calcification can be visualized, but didn't have clear stones on his ultrasonography or any clear data about that can give a clue for this oxalosis. So sometimes it can be different cases. Professor Magdi?
Typical presentation.
I think what Professor Yasser has said is very important. If you have a patient with unknown etiology of chronic kidney disease, especially in young patient, you have to screen for oxalosis. And the mandatory test is to do QP, not a CT and not a ultrasound. Ultrasound will miss nephrocalcinosis, and it can be easily seen in any plain X-ray, QB, just QB. Especially if it's done properly, you may see it. Second thing, you should never transplant a young patient without screening by a whole exome sequencing. It is not that expensive. It's in worldwide, it's less than $500. So you can do it to exclude such disastrous condition, because this patient will need liver and kidney transplantation in the future. And she has lost a graft, and she have paid a lot of money. She traveled to transplantation, and fortunately she didn't get a kidney from a relative. This is very fortunate, because it won't work also. So we need to screen any young patient for oxalosis, and type 1 will only be treated by liver and kidney. If you catch this patient early, you might think of Lumisiran. Lumisiran is an RNA interference molecule which is FDA approved for primary hyperoxalosis, but it should be used early on treatment. And when you find a patient with oxalosis, you have to screen the family also, because it will be present in other members, and it may be dormant up to late years. So I totally agree with what is discussed. Dr. Riyad mentioned that it is very unfortunate to have such diagnosis. And again, there were a question: what was the primary diagnosis of this patient before transplantation? This is a very crucial question, and I usually we for any candidate we have to get the primary diagnosis before transplanting him, for two reasons. One is to avoid such disastrous outcome. Second is to tailor his immune suppressive therapy. So thank you very much, Professor Abdul Hafiz. A very interesting case also.
Thank you, Professor عبد.
زميلتنا.
تفضل دكتور عبد الحفيظ. تفضل دكتور عبد الحفيظ.
اوكي. الدكتورة سحر خلاص طبعا كونسلتنت نفرولوجي كونسلتنت، تشتغل في مستشفى بني غازي، مستشفى كبير طبعا، وهي one of the most active consultants there. She is also the vice president of the our society, Nephrology Society, Libyan Society, and she's very keen to participate and involved in the teaching program. So I give you the floor now, Dr. Sahar. Please start. دكتورة سحر تسمعينا؟ شوف الساوند ممكن يكون مقفول، يعني الساوند.
Go please.
18 years old Libyan male student presented in September 2024 at Nephrology Center with lower limb swelling. Abdominal male student presented in September 2024 at Nephrology Center with lower limb swelling, abdominal distension, fatigue, protein, which started month earlier. Positive family history of grandmother died on dialysis, and his uncle underwent a kidney transplant since long time. Both parents are consequences. Initial finding and management. Examination showed the patient overloaded with normal blood pressure at that time. His investigation at that time present with mild renal impairment, urea 55 milligram per deciliter, and creatinine 1.7 milligram per deciliter. 24-hour collection show heavy proteinuria more than 10 gram per day. Urine analysis show too much albumin and white blood cell and red blood cell. Also show deficiency in vitamin D, a little bit increase in parathyroid hormone, hypocalcemia, and mild increase of uric acid at that time. Vasculitic screening from ANA, double-strand DNA, complement, ANCA, all are negative. Also serology done are negative. Our diagnosis at that time as nephrotic syndrome and advised to receive pulse therapy steroid and sent to him for renal biopsy in Egypt. In current admission in this month, the patient presented again with severe renal impairment, oliguria, and overload, and his renal biopsy did in Egypt, and initial immunosuppressive therapy done from Silsept and low-dose steroid. As you see, this is the patient, is a young, present with severe lower limb swelling and severe ascites. He looks pale and not dyspneic. His blood pressure, which are increasing to 140/90 and controlled with antiproteinuric agent, which started at a count 16. The patient is hyperdynamic with reduced air entry and showed distended abdomen with severe ascites. This is the X-ray of him, show alteration of costophrenic angle. His ultrasound is normal, normal size pot kidney, but high echo with moderate amount of free peritoneal fluid and a small amount of bilateral pleural effusion. This table contains multiple laboratory measured, started from the August. His journey of disease started on August until December. Show the renal parameters which are increasing every month, and the serum albumin at presentation in August and September were low. When he received the pulse therapy steroid and did the renal biopsy and started immunosuppressive agent of the Silsept in Egypt, will be the parameter is a little bit maintained, serum albumin increasing, and then relapse in December present with very high renal parameter. So the vitamin D is not changed, and the collection of a 24-hour protein are at the present time present with 10 grams per day. And after the receiving of immune suppressive, the show little bit improvement in proteinuria, and then again relapse with too much more than 10 grams per day. Current interventions, due to worsening of his condition, dialysis was initiated because of overload and high renal parameter. Patient again in our hospital in this month also received pulse therapy steroid. He's kept in prednisolone 40, Silsept, which are started in Egypt at October, and in our hospital, because of overload and refractory, we start Prograf 1 milligram twice per day. This case highlights a likely genetic kidney disease with rapid progression to end-stage renal failure despite immune suppressive therapy necessitating urgent dialysis. Further work up to confirm the underlying etiology, like genetic testing, renal biopsy finding is crucial. I will show you the renal biopsy which are done in Egypt, show collapsing of a glomerulus with focal sclerosis and segmental sclerosis, and also show detachment of podocyte. The immunochemistry show a granular pattern of the capillaries. This is the renal biopsy. This is the result of renal biopsy done by Dr. Fatma Al-Husseini of the adult, which are aged 18 years, show focal segmental glomerulosclerosis, which are hilar type in more than 50% of glomeruli with chronic tubulointerstitial disease interstitial changes more than 50%. This is the renal biopsy of this man, and this the renal biopsy of his grandmother, which are died on dialysis, show the advanced focal segmental glomerulosclerosis with global glomerulosclerosis more than 90% with marked interstitial fibrosis and tubular atrophy. But the renal biopsy of his ankle cannot be reached because patient until now transplanted, and there is no document of his renal biopsy. My questions, the first is the genetic screen helpful in the management of focal segmental glomerulosclerosis? And what the best anticoagulant using in this adult patient in context of a presence of overload and heavy proteinuria? Is there a rule of rituximab in this patient to save his kidney? What the precautions if the patient plan for a transplant? Focal segmental glomerulosclerosis defined as histological kidney disease injury, which are called disease of podocyte injury. It's account 40% of cases with end-stage renal disease, especially of young age up to 19 years. The most common or the most cases are steroid-resistant nephrotic syndrome. The nephrotic syndrome or on form of focal segmental may be present as a primary, secondary, genetic, and undetermined. Common genetic mutation in this include nephrin in BHC1 or defect in gene budosine in BHS2, alpha-actinin 4 or in gene transient receptor potential cation channel or involved Forum-Libyan 2. Actually, in this patient, the genetic study not done. Overview in focal segmental glomerulosclerosis, the clinical criteria: presence of proteinuria more than 3.5 grams per day, positive family history or of end-stage or dialysis or kidney transplant. Renal biopsy finding presence of the segmental scarring of glomeruli, local or focal and segmental. An electron microscope show effacement of podocytes. Genetic testing should be mandatory to do. Even there is no family history of focal segment, family history of nephrotic syndrome. It should be exclude secondary causes like infection, drug, systemic disease like vasculitis or lupus. Genetic testing in focal segmental glomerulosclerosis in whom and when. This is the study done in November 2023. This show genetic testing is a minimally invasive diagnostic procedure that helps to determine the origin of patient disease, provide guidance on prognosis and future treatment, and enables family screening. However, genetic approach could contribute significantly to shortening the diagnostic process and allow focus on targeted treatment. Importance of the genetic workup if the patient planning for transplant. Focal segmental glomerulosclerosis is mainly steroid resistant due to presence of immune-mediated circulating factors like SU bar mediators, which are not always present in cases of recurrence. However, serial antibodies like CD4T, and other mediators which are predict the recurrence has accuracy to 90%, but unfortunately still not valid and still not used up to now. Budosine gene mutation is helpful in the differentiation of familial from non-familial, whereas non-familial more aggressive and lead to end-stage renal disease, especially in Budosine mutation. In contrast, Budosine gene mutation, if present, it gives more help in its less risk of recurrence after the kidney transplant. In contrast, many studies show anti-CD40 antibody associated with high recurrence rate. Persist proteinuria is a poor marker lead to end-stage renal failure and the risk of recurrence high reach to 60% in younger age group with poor outcome to graft and patient survival. The mean time of recurrence is the 17 months post-kidney transplant. However, many recurrences may occur immediately within weeks, 2 months post-transplant with high rate of graft loss. Effect of persist proteinuria on patient may cause hypercoagulopathy state, which increase risk of thrombosis and thromboembolic complication. Also, it may increase chance of delay graft function because extravasation of fluid due to edema. So it's important to control persist proteinuria prior to transplant. My conclusion, genetic focal segmenta tend to progress more rapidly to end stage, especially in case with podocyte gene mutation. Early diagnosis and supportive care may slow progression, but complete remission is uncommon in familial cause. Thank you.
Thank you, Dr. Sahar, for this case, for this interesting case. Professor Magdi, please.
Thank you very much, Professor Sahar. Of course, focal segmental is one of the challenges in nephrotic syndrome, and especially when you try to figure out how to manage such patient. You raised a very important questions, the role of genetic screening, which is sometimes needed, not always. If you have a biopsy showing primary focal segmental GN, and you have a family history, you don't need to do genetic testing. But if you have a doubtful case with no effacement or non-nephrotic range proteinuria and the patient has chronic kidney disease, you might use it. It's not routine, and usually it has a minimal effect on choice of management. You treat the patient with steroid, then by calcium inhibitor, then you will put another steroid sparing protocol, and if not responding, you might use retox, and afterward you will transplant the patient. You raised the questions, the 4 questions, and I think it's not only for me to answer, but if anyone has answer before I give my opinion, and Dr. Yasser, Dr. Hisham, Professor Riyad, Professor Saeed.
Professor Saeed, unmute yourself, please.
Would you like to comment, Professor Saeed?
السلام عليكم دكتور مجدي، ازي حضراتكم؟
عليكم السلام.
طبعا متشكرين الدكتوره سحر والزملاء الافاضل والدكتور ابو حفيظ والجميع على الكيسز الانترستنج وكده. طبعا زي ما الدكتور مجدي قال ان الفوكال سيجمنتال من الامور التشالنجنج في النفروتيك سندرومز، وهي الدكتوره سحر استفاضت مشكوره في موضوع يعني ازاي تميز ما بين الجينيتيك فورم والبرايمري والسكندري وخلافه، وده فيري كروشال. يعني المفروض قبل ما ناخد اي خطوه في العلاج ان احنا لازم نحدد تايب اوف فوكال سيجمنتال جلوميرولوس، اي مين ايتيولوجيكال وايز. لماذا؟ عشان لو هي برايمري اوكي اوكي، ويبقى وارد ان انا هعالج ب immunosuppressive medications. لو هي genetically determined يبقى حرام ان انا هدي عيان او مريض اديله immunosuppressant unnecessarily واعرضه للسايد افكتس بتاع الاميونوسبريشن ومش هتجيب نتيجه، بل بالعكس هاخد منها السايد افكت. قس على ذلك بعد كده الجزئيه بتاع الترانسبلانتيشن والريكارنس ريت فيها. الريكارنس طبعا اكتر في البرايمري من الجينيتكس، وان كان في بعض الجينيتكس فيها ريكارنس بس طبعا مش بنفس الدرجه بتاعه البرايمري، ولازم يتعمل جينيتك ستادي عشان كده. الجزئيه الثالثه ان بالنسبه للريكارنس المفروض تبوت انتو كونسيدريشن التايب بتاعها. احيانا بيبقى في كلينيكال بعض الارهاصات كلينيكالي تقول ان ده يمشي مع البرايمري اكتر من الجينيتكس او العكس. يعني لو رابيد ديتيريوريشن اوف كدني فانكشن او سيفير بروتونوريا واتنقلت للنفروتيك رينج بروتونوريا من السب نفروتيك للنفروتيك، او زي ما قلت ديتيريوريشن للكدني فانكشن وزين شورت تايم او كده، ده بينبئ الى حد كبير ان ممكن ده تكون برايمري راذر جان جينيتكس. ولكن الفيصل في الكلام ده طبعا الجينيتك ستادي زي ما الدكتوره سحر نوهت، وبالتالي اي ثينك مش عارف دكتور مجدي يتفق والاساتذه معايا ولا لا، ات از مانداتوري ان احنا نعمل جينيتك ستادي تو رول اوت اور ان ده جينيتيكالي ديترمند ولا برايمري تايب، للاسباب اللي حضراتكم ذكرتوها وانا ذكرت بعضها دلوقتي. شكرا جزيلا.
Thank you, Professor Said. Any more comments?
نو مور كومنتس. كومنت دكتور مجدي عشان ننتقل للحاله الثانيه. اتفضل.
Okay. I think we summarize this case nicely, and we have to move to the next
Okay.
case.
Okay. A question. There is a question. Is plasma exchange effective in this case?
No.
No.
Short answer.
Okay, there is no antibodies.
Yes, yes.
It's not.
Okay.
It's not an immunological disease, so there's no
Yes,
way,
yes.
no benefit.
Totally agree.
No.
الحالة اللي فاتت كانت حلوة بصراحة. Last case was very interesting as well. يعني genetic form of focal segmental glomerulosclerosis. Now we have another presentation from our colleague Professor Nada Khalid Al-Bibi. She is from Misurata. She is a very distinguished consultant in Misurata. She is also a kidney transplant patient. If I say she is a professor and a patient the same way. She is very, very active. And we would like to hear from her today about one of the very interesting cases. So the floor is yours, دكتورة ندى. تفضلي.
السلام عليكم. الصوت مسموع دكتور؟
اتفضلي
صوت
حضرتك.
كويس.
يس كويس. اتفضلي جميل.
السلام عليكم. شكرا للجمعية المصرية وشكرا للجمعية الليبية. شكرا دكتور عبد الحفيظ. Our case presentation today, we have 45 years old Libyan male presented to nephrology clinic, complain of bilateral lower extremity edema, fatigue, and weight gain, which had progressive worsening over the past 2 weeks. Estimated GFR has been declining gradually and raised concern of worsening renal function, which promote the patient to seek the medical advice. Past medical history, the patient, the patient is a non-case. Yes, it's clear, doctor. The past medical history, the patient is a non-case of since 10 years as a minimal change disease, which at presentation he is present with nephrotic range proteinuria, lower limb edema, hypoalbuminemia, and present with normal kidney function. That's presentation since 10 years back. And the patient kidney biopsy done for him and confirm minimal change disease, which treated by standard management of minimal change disease, steroid over 6 weeks, which they normalized of proteinuria and resolution of edema. After remission, the patient maintaining on low dose steroid and occasionally relapsing requirement brief course of steroid therapy. This is the report for biopsy, which are confirmed minimal change disease. Over the last month, 6 months, the patient experienced worsening of edema fatigue, and weight gain. He's hospitalized multiple times for acute episode, which are treat as a frequent relapse or relapse minimal change disease. At admission was proteinuria, albumin creatine ratio was 500 milligram per gram, serum albumin was 2.7, and GFR was declined. This is over the last 6 months. When presented with the patient, he was nephrotic syndrome with declined kidney function. And now for us, we are dealing with patient the minimal change disease with decline kidney function. We are on presentation. Family history, he's declined any family history of disease or same illness. When presented for us, the examination, the patient significant lower limb edema, blood pressure 150/90, urine output 1,800 ml per day, and he is stage 1 obesity, physical examination only lower limb edema. Work done for the patient, urine analysis showing protein 3+, no microscopic hematuria, serum albumin 2.45, serum creatine 1.4, which is slightly elevated from baseline 1. Estimated GFR is declined 63, at the baseline 95. Lipid profile, total cholesterol 300, LDL 200, triglyceride 350. Another workup done for the patient, complement was normal, serum protein electrophoresis, serum viral screen, ANCA, C ANCA, B ANCA, anti-nuclear, antiphospholipase A2, all there are negative. And another biomarker only have slightly elevated parathyroid hormone, C-reactive protein was 6, and mild microcytic normochromic normocytic anemia. Urine analysis 24-hour 3,500 milligram per day protein, albumin creatine ratio was 600 milligram, and ultrasound for kidney, the right side was 9.5, left kidney was 10 centimeter. Ultrasound Doppler for kidney is normal, chest CT scan for chest normal, echo normal. After exclude, we do workup, we are obtaining for consent from the patient to perform another kidney biopsy. This is the result for another kidney biopsy. Giving the patient frequent relapse, minimal change, and worsened kidney function, the renal biopsy with obtaining performed light microscopy, several glomeruli showing area of segmental sclerosis with some demonstrated fibrosis consist with focal segmental glomerulosclerosis. Immunofluorescent negative electrode microscopy, their effacement of podocyte and fibrosis. Final diagnosis, the renal biopsy finding, we are consist with the diagnosis of focal segmental glomerulosclerosis superimposed on previous history of minimal change disease. Our management of our patient, now the patient is conferred as a focal segmental glomerulosclerosis with nephrotic syndrome. We are start by supportive therapy. We are start of angiotensin converted enzyme, enalapril 10 milligram daily to reduce proteinuria and renoprotective, and diuretic furosemide 40 milligram to reduce the management edema, and we start immunosuppression. We are as a development of focal segmental with frequent relapse, we initiated a tacrolimus or Prograf as a dose started by 0.5 milligram per kg per day, 2 milligram twice daily as a part of regime to maintain reduced proteinuria. And we are adjustment to maintain therapeutic blood level between 4 to 7. The other medication is start statin and low salt diet and fluid resection for recommended to help the manage proteinuria. This is the parametry of evaluation for our patient. When came our patient, albumin creatine ratio was 600 and serum albumin was 2.5 and GFR was 63, and we follow up patient 2 weeks, 3 weeks, 6 weeks, and after 3 months patient albumin creatine ratio was 350 and serum albumin 3.4. After 6 months, the patient albumin creatine ratio was 320 and serum albumin 3.6. But his estimated GFR is stable, but little bit is decline, 58. So the monitor our patient closely by albumin creatine ratio and renal parametry and ultrasound. The outcome after 6 months of initiated of tacrolimus, our patient experienced reduction in proteinuria, and finally after 6 months, albumin creatine ratio 320, and serum albumin is improvement 3.6, and the kidney function remains stable. GFR 85 ml/min, suggestion of degree of chronic kidney disease. Our patient is will continue on the medication. Our planning for 1 year or more, and with regular follow-up and assessment for kidney function. This is the normal light microscopy, a normal glomeruli and electrode microscopy, and this is for our patient. This is light microscopy for our patient. This is the first report from our patient as a diagnosis as a minimal change disease, and this is the electrode microscopy. There is effacement of podocyte, and this is the second biopsy which done from when it presented for us, done in Tunisia. This focal in the light microscopy, there is focal lesion, and there is podocyte and podocyte injury in electrode microscopy. And we are concerned from patient about the public of imaging and the reporting. Discussion, the nephrotic syndrome is characterized by nephrotic range proteinuria, hypoalbuminemia, edema, dyslipidemia, and the minimal change and the focal segmental are the main to major form of nephrotic syndrome. As we know, the minimal change disease is the more common in the children. About 70 to 90% account for children and 10 to 15% in the adult. And the minimal change is a benign disease. And the minimal change is the benign disease. But the
بعد هذه 5 دقايق خاصة المفروض يعني كملنا واجد 4 حالات.
Continue, doctor.
دكتورة ندى استمري يا دكتورة ندى.
We can't hear you.
اوكي كويس دكتورة اسمع فيها.
بليز كاري اون. انت قريبة تخلصي ولا؟
كملتي يعني؟ خلاص قريبة، مش عرفت سلايد بس في مشكلة. اوكي. Pathology there in the light microscopy, maybe the minimal change disease is light microscopy normal, and immunofluorescence there is no staining or deposition on the immunofluorescent. Electrode microscopy there is effacement. The minimal change disease is benign and could respond to corticosteroid, and it's rare to progression to end-stage kidney disease. And the focal segmental glomerulosclerosis is a disease, there's sclerosis in the light microscopy, maybe primary or secondary. Primary, there's more aggressive and more progression to end-stage kidney disease, and we have more effacement on electrode microscopy to differentiate from secondary. Secondary, there are less aggressive, and secondary is more response than the primary focal segmental. The secondary cause, as we know, there's genetic, as Dr. Sahar mentioned for us, and there's a viral infection, a drug, or as we know, there a diabetic patient, hypertensive patient, they're highly risk for focal segmental glomerulosclerosis. There's factor to transmission or transformation, minimal change disease to focal segmental glomerulosclerosis, chronic podocyte injury, as inadequate treatment or steroid resistant. The one is reason for transition. Steroid resistant, glomerular hyperfiltration, as we see in the obesity and hypertension, genetic infection like HIV and autoimmune disease, overuse of medication like non-steroidal or antibiotic. Diagnostic challenge. The focal segmental is the focal disease. So the misdiagnosis as a minimal change disease. especially in the early lesion or early disease. Renal biopsy, a quality, especially a number glomeruli sample, is important to make accurate diagnosis. So the challenge, if this patient was minimal disease or it was focal segmental from the beginning, is the error in the sampling during biopsy, and this is a challenge for us. So the conclusion, transition from minimal change disease to focal segmental glomerulosclerosis, rare but significant. The focal segmental more resistant to steroid and highly progressive to end-stage kidney disease. Chronic podocyte injury, steroid resistant, frequent relapse, and glomeruli hyperfiltration is one of cause or related cause to transition. Early organization of steroid resistant or frequent relapse is important. It may be signal to development or coexistent the focal segmental. The biopsy sample should be carefully evaluated, as a focal segmental is a focal disease and can lead to diagnostic error. Early diagnosis, adequate sampling, a trigger to the management important to prevent disease progression and improve the outcome in the patient with nephrotic syndrome. My message. So maybe it's a challenge for us. If patient is from beginning he's a focal segmental and there is misdiagnosis, or there is transition from minimal change to focal segmental glomerulosclerosis.
Thank you.
I don't. This is channel even for me. I manage my patient now as a focal segmental glomerulosclerosis, and my patient he's concerned about the progression of disease and the transplantation, and if he's donate from his family, what's the precaution will take from the patient. Thank you.
Thank you. Thank you very much.
Thank you very
This
much.
is the concern. Thank you. This is the concern of Dr. Rami Abu Bakr, who said that it is mostly if SGS from the start, with the age of the due to mainly the age of the patient favors this. I have a question. Diagnosis depends only on finding no lesion on a light microscopy. You didn't do any further microscopy such as electron microscopy or something for the patient.
Already yes, huh? There is light microscopy, but the patient I contact with his doctor. The patient he's lost the result, but even I don't know. I don't sure about the result.
Didn't do about.
I don't even me. I didn't sure about electrode microscopy result for first sample. Yes.
Okay. So Rami,
yes, maybe he's from beginning. He was focal segmental. Even me, I don't sure about is accurate about the result from the first sample.
Okay.
Professor
Magdi?
Yeah, thank you very much, Dr. Nada. It's again interesting case of focal segmental, but it raises an issue when you have an adult patient, especially at the age of 35, with proteinuria and GFR reduction, and you got a just light microscopy with minimal change. You should suspect focal segmental, and you should treat him like focal segmental. You give steroid therapy at the start. If no response, you will shift to the same protocol, or you may take another biopsy for electron microscopy. You mentioned the very important issue. Biopsy in focal segmental should be enough, should contain a lot of glomeruli, and it should contain cortical as well as some deep cortical or medullary glomeruli. The medullary glomeruli, this is where the first sign of focal segmental occurs. So this patient should be considered from the start focal segmental, because up till now the dilemma of minimal change going into focal segmental is not solved. So when you have such patient, you manage him well, and I think this is the best you can do for your patient.
And I think the treatment is somewhat similar.
Yes.
Treatment lines are somewhat similar.
Yeah.
Okay.
Exactly.
Thank you, Professor Magdi. And Professor Hisham said a comment that they are one spectrum of the disease, different stages.
The same disease.
Okay, and because of this, the treatment is similar. We came to the end. No more comment and no more questions. And thank you, Professor Abdel Hafiz and Libyan Society of Nephrology and Transplantation for this interesting session and these interesting cases. And thank you, Professor Magdi Sharqawi, for joining us as a moderator today in this very interesting session, and thank you for all professors who shared us. Thank you, Dr. Hisham Al-Sayed, Professor Saeed Khamis, Professor Riyad Saeed, and for all of for Rami Abu Bakr specifically in again for his work, and for all of attendees for their active share and for joining us and remaining with us for this session. Thank you, and excuse me to close this session.
Thank you.
Thank you. Thank you. Bye bye. Thank you everybody. Thank you.
السلام عليكم.
عليكم السلام ورحمة الله. في أمان الله. السلام.
ساعدنا